Good afternoon, everyone. My name is Yolanda Vera, and I'm the Senior Deputy for Health and Wellness for Supervisor Holly Mitchell. And thank you for joining us on today's Lunch and Learn. We wanted to have a session, and we've invited numerous county cities to attend, to explain the impact that HR 1 is having on our health safety net and why tomorrow the supervisor and her colleagues will consider a motion to place a ballot, a temporary ballot, for a 0.5% general sales tax initiative that will be used to support the county safety net system. I'm thrilled to have the speakers here who will explain the impact on the health safety net. I'm going to introduce them all together, and then we'll hear from them one at a time. We're going to have roughly 35-40 minutes of presentation, and then we'll open it up for questions. We'll be monitoring the chat to see if you have particular questions. Just a few preliminary things. One is if you are not speaking, if you could please put yourself on mute unless you are speaking and your camera off. Your camera can be on. And then secondly, just the speakers that we have are experts in health delivery systems. They are not experts in taxation. So just please take that into account when you're asking your questions. So with that, I will introduce our speakers. We will first hear from Dr. Christina Galley, who heads the Department of Health Services in Los Angeles County, which is among the largest, I think second only to New York, public health system, delivery system in the country. She'll explain what her department does and how HR 1 impacts it. Next, we will hear from Dr. Barbara Ferrer, who heads the Department of Public Health, again, one of the largest public health systems in the country. And then we're going to hear from Louise McCarthy, who is the CEO of the Los Angeles County Community Clinic Association. And they run a network of free and low-cost nonprofit community clinics that provide healthcare services throughout Los Angeles County in about 600 sites to almost, I think, 78 different cities. So without further ado, I am going to ask Dr. Galley to please turn off her camera and turn on her microphone, and please present.
Thank you. Thank you, Yolanda, and thank you to the entire Second District team for hosting this, and really happy to be here. Thank you to those cities who are joining. I'll provide, as Yolanda stated, a brief summary of the services that is provided within health services, and then talk a bit about the impact that we're facing from the cuts predominantly at the federal level, and what the impact would be of the proposed sales tax if approved. And of course, happy to answer any questions at the end if there are any. The Department of Health Services is a large department within the county. Our mission is to advance the health of our patients and communities by providing extraordinary care, and we do that through several different mechanisms, the largest of which is our network of hospitals and clinics. We operate 4 public hospitals. That includes LA General Medical Center in Boyle Heights, Harbor UCLA Medical Center in Torrance, Olive View UCLA Medical Center in Sylmar, and Rancho Los Amigos, which is both an acute care hospital as well as a national rehabilitation center for acute rehabilitation services in Downey. We also operate a network of 23 community clinics. Many of those clinics are quite large. And overall, all of those different components of the system provide comprehensive services to predominantly low-income patients. Over 90% of our patients are on Medicaid or uninsured. We provide primary care, specialty care, rehabilitation, diagnostic services. Our hospitals are some of the busiest emergency rooms in the county. We provide over 250,000 ED visits per year. We have about over 1,000 acute inpatient beds. And we really serve not just the people that come to us for services, but also just really people who are in urgent moments of need and crisis. We operate two level one trauma centers. We operate one of the county's only burn center and take referrals from across the county for patients who have experienced severe burns. We also operate the county's inpatient and emergency psychiatric services. Uh, and also run a number of graduate medical education programs. We train well over 1,500 residents per year in a variety of medical and surgical training programs, really helping to build up the next generation of physicians. Uh, I'll provide a little bit less detail, but still do want to cover the bases on the other services that we provide. So we also provide healthcare to the individuals who are within the LA County jail system or the youth in the probation housing camps. We operate the Office of Diversion and Reentry, which diverts individuals with serious mental illness from the jails into community, and provide harm reduction services for individuals struggling with substance use disorders. And with that, a lot of community-based services and supports as well. And then we also run the EMS agency. Local jurisdictions and counties are given authority to run their own EMS agency. It provides all of the oversight over pre-hospital care, as well as provides the process for designating base hospitals and specialty care centers within the County of Los Angeles. And that includes designation of trauma centers, stroke centers, STEMI, which is heart attacks centers, as well as other specialty centers. Could you go to the next slide, please? So this is a little bit of a busy slide, but I'll walk you through the numbers. And this just provides a summary of the threats that we're facing over the course of this year and the following 3 years after that. The biggest threat is on the federal side, but I did want to briefly mention some of the challenges coming from the state as well. The state has chosen to make several changes in terms of how individuals are potentially eligible for Medi-Cal. They've put in place an asset limit, an asset test, and an asset limit before individuals can qualify for Medi-Cal, which is Medicaid in California. They have frozen enrollment for individuals who are undocumented. The state previously had put in place a program where individuals who were undocumented would be eligible for state-only Medi-Cal, including full coverage of services, and they have put a freeze on new enrollment in that program. And then there's also now a premium for participation in that program for non-senior adults. And in total, those changes, it'll ramp up over the next few years, but it'll end up within 3 or 4 years costing about $50 million a year to DHS because we will have fewer individuals who are uninsured. And I'll touch in a minute also on just that broader impact of the patients who are going to be uninsured, which is really a theme that we're anticipating, sadly, having to face in the coming months and years. Shifting to the federal side, the HR1 bill, or what's known as the Big Bill, included really devastating changes for hospitals, both public and private hospitals alike, for how they manage a complex system of payments in Medicaid called supplemental payments. And then also it ties in with the need for the federal government to renew a Medicaid waiver. I won't bore you with some of the details about those payment mechanisms, but I think the important point is really just those numbers on the slide, that by full implementation of HR1 and the limitations that it places on us to be able to draw down public funding, as well as the limitations, similar numbers, I'm sure, facing many private hospitals, we are looking at losing close to $500 million per year annually by 28-29. Our entire health system is about 6.5 billion, so this represents a sizable portion of our budget and really makes a dire fiscal situation in the future. I mentioned a minute ago Medicaid enrollment changes. Just as the state produced limitations on Medicaid enrollment and eligibility, the federal government did as well, but went even farther. There's lots of limitations on the flexibility of how enrollment is done. Individuals will now need to apply and be deemed eligible for Medicaid every 6 months. And then there are new work requirements for individuals, a certain segment of the population, in order to maintain their Medicaid eligibility. And taken in total, those will have an impact of about $140 million a year. Again, because people will no longer be eligible for Medicaid and they will fall back to being uninsured. And then lastly, there's some changes in terms of how we're paid for a portion of the population that seeks emergency services, which will cost about $60 million a year. And this will affect public hospitals and also private hospitals alike, where previously hospitals were able to enjoy still insufficient but somewhat higher payments for individuals seeking care in emergency rooms, and now those payments will be cut. In total, the total impact on DHS from just this set of particular state and federal legislative changes will cost DHS about $725 million a year. This is really catastrophic for any health system to try to sustain. And so we are working feverishly in partnership with the county to think about different options for managing this. We are certainly, of course, looking at efficiencies, how we can be more cost effective with the services we provide, but we will also, unfortunately, if these issues aren't able to be resolved, we'll need to look at service cuts. And I think when people think about public hospitals, they may not really understand or always think about how much all of our lives depend on having vibrant public hospitals. And I want to just highlight two. One is, or three. One is just simply the availability of emergency room services. We have, as I mentioned, very large ERs, very busy ERs, as well as many private hospitals do also. And that affects everybody, regardless of whether someone is on Medicaid or is uninsured or has commercial insurance. As we see hospitals close, or as we see hospitals no longer able to provide comprehensive services, individuals are really going to be transported farther to care. When they need to call 911, they're facing longer wait times within the 911 system. And this has the potential to impact really the health system at large, in addition to the potential focused impact of the loss of some of those specialty care services that I mentioned. So if a hospital needs to close and it operates a trauma system or a burn center, as LA General does, that really would have large impact on the overall system and the patients that rely on the specialty referral services for care. The uninsured is also really a challenge. And I think sometimes when people think about this, they think about it from two different perspectives, and I think both are important. One is for the individuals themselves who are uninsured, and they live within all of our communities, and all of you all, I know, have individuals who will face losing their insurance coverage as a result of these steps taken by the federal government. And this is really challenging for those individuals and their families, as they no longer have the protection and the healthcare coverage that insurance offers them. And so now they may be less likely to seek preventive care services within a public clinic or a clinic within the community. They may face worsening health conditions, an exacerbation of their chronic diseases and illnesses, and just face worsening health consequences for themselves and their families, and that's catastrophic for them. They may also face higher medical debt or payments that they need to make if they seek services within a private hospital system or clinic system that does not have robust charity care policies. Those are challenges, but I really just want to remind everybody that even if it's not, there's broader impacts than also just the patients themselves that might be uninsured. When the number of uninsured go up, this has spill down effects on the entire healthcare system. Patients, when they're newly uninsured, will seek care less in clinics and more in the emergency room. Emergency rooms will become more and more crowded at the same time that hospitals are going to be facing increased fiscal threats that I described and be at the risk of service cuts and closures. And that has spill down effects for everyone in the population. I'll close with just really accentuating why The sales tax then is helpful in seeking to solve at least a portion of these problems. First, a large portion of the tax goes to supplementing and filling some of the cuts that were made by HR1 and helping to build back up the stability of the services for the sake of the broad LA County population. And that's critical. Equally large portion of the tax also goes to building up a system of coverage for individuals that might be eligible for Medi-Cal, but because of these changes on the slide, will no longer be able to receive full coverage under Medi-Cal. But they still desperately need services, and we all collectively need them to not go to the ER to receive those services. So this tax would build up a coverage program for people in all of our different communities to be able to access the service that we need in the most comprehensive mechanism possible. I will pause there. Happy to take questions now or also at the end.
Thank you, Dr. Galley. I think what we'll do is we will turn it over next to Dr. Ferrer to provide some remarks and invite you to keep your camera on and stay so that we can answer questions towards the end of this. Dr. Barbara Ferrer.
Yeah, thank you so much. And good afternoon, everyone. I'm hoping everyone can hear me. And I want to just really appreciate everyone who got on the call. Times are really tough and challenging. I appreciate your willingness to spend some time with us. We can go to the next slide. I'm really wanted to talk about sort of the impact of changes at the federal level on public health funding. Our mission here is to advance the conditions that support optimal health and well-being for all. And most people are very familiar with our work, but I'm going to go through in particular the work that we do on behalf of the contract cities. At first, just an overview of what our budget is. We have a large budget, as Yolanda noted when she introduced our conversation today. We are the largest county health department in the country. The budget's about $1.9 billion. About 3/4 of the budget, about 73% of our budget, actually comes from federal and state funds. The county dollars that we get, those NCC dollars, are about 13%. An important 13%, however, because oftentimes our grants, which tend to be restricted in nature, we get a grant to do a particular activity. Communicable disease is one area where the federal government gives us a fair amount of funding. If the costs of doing that activity are not covered by the grant, we do rely on those county dollars to make up the difference. The same thing, we charge some fees, particularly around environmental health services. For some of those services, it doesn't cover all of our work. And again, what we've done is braid all of these funding sources to allow us to best serve people all across the county. I'll go to the next slide. I think it's important to note that, we, like other public health departments and like the county as a whole, face some significant challenges. In the context of HR1 and federal reductions in support, out of that estimated $2.4 billion, which is a projected loss here in the county because of the federal government actions, we here at our public health department see immediate and sustained impact because of the funding cuts. First, I want to note that federal, state, and local revenue losses to date already account for a $70 million loss. And we're just in February. We anticipate over the next 2 to 3 years, with the implementation of both HR1 and other federal grant reductions, we'll lose about $200 million in funding. And because of the current funding crisis and the structural deficits that are now getting built into our budget, we've already had to take some pretty significant actions, including closing 7 of the 13 public health clinics, curtailing our disease investigations, which means, for example, when we discovered dengue mosquito pools in one of the neighborhoods, we were no longer able to do a wide net community outreach. So we could not send people door to door in that neighborhood, alerting them to the presence of mosquitoes that were infected with the dengue virus and the steps that they needed to take. We had to have a significantly reduced presence in those neighborhoods. And the same applies for just general community education and outreach activities, many of which we partner with your teams on and do at the request of cities. We've lost here a significant number of staff. They've been either reassigned. Most of our contract workers are gone. And sadly, we're in the process of doing some workforce reductions. So an immediate impact when we lose staff, we lose services. And this is all happening at a time where we have increased demand for the work of a public health department. We have a lot of need for increased responses to environmental hazards. Some of your cities have been places where you've asked us to come in and help manage different impacted neighborhoods from things like water, air, soil, waste hazards. We also have had to reduce our mobile services. These particularly serve vulnerable populations, including people experiencing homelessness, elderly people living isolated or in congregate living, and people who are living in communities with less access to medical services. Outbreak management is also way up. People are asking us, there are more outbreaks. We're in the middle of responding to the third measles case in a matter of 2 weeks. Every measles case requires us to have 40 to 50 staff to go and identify the contacts and really try to prevent what's going on in South Carolina, Florida, Texas from happening here. Each event, each measles case costs us on average somewhere between $200,000 and $400,000, depending on the extent of the exposures. And with lower vaccination rates, sadly, we have increased requests to manage potential outbreaks. There also, as everyone knows, is increased demand on us to help with safety at large events. The World Cup is coming up, the Super Bowl next year, and the Olympics the following year are some of the highest profile events. Public health does not usually receive any additional funds to support these events. And we need our team to be able to, for sure, participate fully, both in the planning and the execution of safety plans for each of these large scale events. Next page. We are under contract with most of the cities in LA County, the exception being Pasadena and Long Beach. And our contract calls for us to perform a whole set of duties that comply with state mandates. The state mandates that there be a vibrant county health department and that the county perform a whole range of services that I've tried to outline here. That includes we have to do birth and death records and public health statistics. We have to do all of communicable disease control. There's about 45 reportable diseases to us. We provide medical and nursing services that promote maternal and child health. We do, as you all know, a lot of environmental health and sanitation services. We're required by law to run health education programs, to have laboratory services capacity, to provide public health nursing services in particular areas like TB, and to offer services in nutrition, chronic disease prevention, family planning, and address the social determinants that affect health. We also, as you know, provide additional services as stipulated in the contracts to make sure that, in fact, we're meeting the needs in all of the cities across the county, and we do that at no charge. So there are no fees for this. Obviously, as I showed you, we receive money from both the federal, state, and local sources to help fund this. But again, when there's a reduction in those services, these are the areas that will be impacted. Communicable disease prevention, mitigation, our surveillance, so that we know what's going on. We inspect and license to ensure food, water, housing, healthcare facility, and worker safety. Some of that is reimbursed by fees, some of it is not. We have services for vulnerable communities that include home visiting, our student well-being centers. We're at almost 50 schools. We have public health clinics and mobile services. While reduced, they can be reduced even more should we continue to lose money. We serve children with disabilities in our Children's Medical Services Program. We are the provider for residents with substance use disorder through a network of treatment providers, and we engage in such activities as medical debt reduction. We're also known for the work that we do around emergency preparedness and response for disasters, public health crises, and critical events. The next slide. So if we continue to lose money, because that's what the federal government is proposing. I mean, every day here, we get a notice. Today, the president announced he's clawing back $600 million in CDC contracts from California alone. So just about every day, there is another onslaught from the federal government on essential public health work. But it will translate directly into reductions in critical health services, which if folks don't have access to these services, they end up, as Dr. Galley noted, relying heavily on the emergency rooms, which then means that the emergency rooms become places that are backed up and where it's hard to get seen for any emergency because so many people are utilizing them as their only option for healthcare. We also will have severe restrictions in the community health services that we're offering, which benefit clients across the board. Our home visiting programming, our nutrition programs, for example, SNAP Ed was cut. That was helping with food distribution at over 45 sites. Water testing, we have a grant that covers water testing 6 months out of the year all across our beach coast. Should we continue to lose money, we don't have any capacity to test in the winter months, the winter and spring months. These are really real and profound reductions in services. I think the last two, though, are what are most worrisome. Our reductions in communicable disease control activities, outbreak management, being able to gather information about what's going on, those affect everybody. We all learned that during COVID. There's no boundaries to the spread of disease. If we are unable to be successful in, for example, following up with every single measles case and identifying close contacts and figuring out whether they're immunized or at risk of either both contracting measles and passing it on to other people, we end up in a situation like you've seen in Florida and South Carolina and Texas. One of the ways to make sure that that doesn't happen here is to make sure our communicable disease side of the house continues to have all the funding that they need to do the work. That includes helping to make sure people have access to affordable vaccines as a primary way to stop the spread of many communicable diseases. It also means our inability to really be as responsive to environmental hazards. We have long understood at public health departments the need to be able to prevent and respond to communicable diseases. We have an increasing and growing need to be able to respond to environmental hazards, to mitigate when there are environmental hazards and they're resulting in dangerous exposures to residents, but also to prevent the exposure to these hazards. And that work is in jeopardy. And that, again, these are issues that affect everybody. All of our water, all of our air, all of our soil depends on there being a vibrant public health department here in LA County. And these are services we provide free of charge to all of the cities. Next slide. Which might be my last slide. Yep. So again, I'm happy to answer questions after Louise speaks.
Thank you, Dr. Ferrer. I appreciate your comments. And why don't we turn it over to our last speaker, who is Louise McCarthy from the Community Clinic Association of Los Angeles County. And Louise, if you could turn your camera on and provide us some comments about the impact of HR1 on the network of free nonprofit community health centers. Thank you.
Excellent. Great. Thank you, Yolanda. And I'm really glad to be presenting with our partners, Doctors Ferrer and Galley, because we really comprise the public and private healthcare safety net together. It should be noted that our association, the Coalition of All Health Centers across Los Angeles, was founded in the 90s when LA found itself in an absolute crisis and was looking at closing sites, shutting down services. And we came together to try to find ways to preserve care for Angelenos. So it's interesting that that partnership started 30 years ago, remains strong and really critical for what we're looking at in this moment in time. So next slide, please. So I'll be just one snapshot of who are the community health centers. So these are for those of us like healthcare nerds, there's what are called federally qualified health centers, which receive some federal grants, which you can see which does not actually make up very much of their funding. It also includes free clinics. It includes community clinics and Planned Parenthoods. So they are located all across LA County at over 600 health center sites. They are all the way from Antelope Valley down to Long Beach, from Venice into the San Gabriel Valley. And I just what they do at these sites. You've got full-time, brick and mortar community health centers that are providing comprehensive care, medical, dental, behavioral health, which includes mental health and substance use services. A large number of them also work in supportive services, such as in helping people get enrolled in programs, helping people find housing, working in food insecurity. And it should be noted that they're all employers. And unfortunately, Axios News recently reported that the healthcare job growth has powered our labor market nationally, and that because of the impacts of HR1 is stalling out. And so these are employers in our communities. And notably, they are healthcare, just writ large, is the largest job growth sector for middle skill jobs. So this is for anyone with a high school equivalency and up. So people get hired into healthcare and they move up the career ladder. So healthcare is where opportunity happens. So these health centers, as noted, the majority of the patients they serve are on Medi-Cal, 76%. 9% are uninsured. You've got also similar number of private insurance and Medicare. But Medi-Cal has really fueled the growth that health centers have experienced in the last 14 years. So if you look at the chart on the right-hand side, you'll see that health centers went from 32% Medi-Cal to 76% in that time frame. They went from 59% uninsured to 9% uninsured in that time frame. And that because of that increase in coverage, they were able to increase the number of patients that they served from 1 million in 2011 to 2.18 most recently in our current year. So this job growth, so all of these cuts that Doctors Ferrer and Galley talked about that impact our Medi-Cal program are going to constrain our ability to maintain these increases in access that we've had. So 1 in 5 Angelenos are served by a health center. For folks in LA County that are on Medi-Cal, a third of them are seen at health centers. And 60% of the revenue that comes into community health centers comes from Medi-Cal. So additionally, thinking about the health centers, they're noted, they do a significant amount of service for people experiencing homelessness. Around 85,000 people experiencing homelessness access their care to community health centers. And they may get that through street medicine or through the brick and mortar sites. They're getting behavioral health services, substance use services, mental health, you name it. Their health centers are also providing this care at school-based health centers, at school sites. They have mobile clinics. So they really look at where the need is and they go to it. If we go to the next slide. Okay, actually, next slide. Here we go. So this is what I sadly refer to as our timeline of terror for what's coming to us has already coming and has already hit. So we know that there will be decreased coverage, and when people don't get covered, they still need care. And so the safety net, public and private, will do their best to serve them. So starting in January of this year, as Dr. Galley mentioned, the folks that were in the Health for All expansion, their enrollment was frozen. So if you're not in covered, you can't get in. And if you fail to re-enroll, you can't get in, back in. So we're looking at about 450,000 enrollees in LA who are at risk of losing coverage. July of this year, those same folks will, if they stay covered, they'll lose their dental coverage. So that means if they need any dental services, they'll either come and get uncompensated care from the community health centers, or they'll wait and dental emergencies are often seen, unfortunately, in the emergency rooms. January of next year, work requirements will be implemented. And that is for the Health for All expansion, as well as the folks that were in the Affordable Care Act expansion. Every 6 months, they're going to need to show that they are meeting the work requirements criteria. And the estimate is that 1.5 million folks in LA risk losing their Medi-Cal coverage. And I want to note that of those folks, in particular, the people experiencing homelessness will have the hardest impact. Their ability to document their work status, as well as their ability to do it every 6 months. It's not easy to enroll in Medi-Cal. And so they will be falling off of coverage and they will be seeking care. And to their best ability, the health centers will serve them without compensation. The second piece of this is that there's elements of decreased payments, which are going to add to the financial strain. For folks July of last year, the Planned Parenthoods were barred from Medicaid. 85% of their patients are on Medi-Cal. So they will not get paid and not gotten paid since July for serving 85% of their patients. Additionally, this July, and this is unfortunately a state budget decision for the community health centers, the payments that they get for Medi-Cal for people who were part of the Health for All expansion will be cut. And so about 25% of their patients will now have a lower reimbursement rate. That is going to impact community health centers to the tune of $400 million a year here in LA County. So $400 million a year in losses. So in summary, as we're looking at the impact, the numbers that you saw from Dr. Galley, the numbers that you saw from Dr. Ferrer, and here, we are looking absolutely at a crisis that folks will lose coverage. Our safety net services will be strained, and there's really no way to maintain the gains that we've made in the face of these changes. So I'll wrap it up there, and I'm looking forward to the conversation.
Thank you very much. I'm going to ask that our speakers put their cameras on, and anybody else who wants to put their cameras on. And for people who have questions, to please type your question in the chat. And as people do that, I'm wondering if our speakers can make a comment of what our county would look like if the county service is gone. Where would people go? You started to hit on that, but if you could touch on that briefly as we're starting to get questions from participants.
I'm happy to start and I'll let others chime in. Put as succinctly as possible, it would really overrun the emergency departments in the county. The volume in the ERs is already high. A lot of emergency rooms are struggling. If anyone has unfortunately been to an emergency room lately, you know how long it can take to get services, and the volume would just go up because individuals don't have, quite simply, another accessible form of care. Federally qualified health centers and public clinics will do their best to maintain access for everybody, regardless of insurance status. That's a reason for existing. But there's only so many sites depending on the degree of the funding cuts. And that would be the unfortunate reality that people would face. And then again, I think for DHS, it's also the loss of those specialty care referral centers that the general public really does rely on, such as trauma centers and burn, and then the loss of the future physician workforce due to the potential closure of graduate medical education training programs.
I think for public health, it's a little bit different. And, I'd like to say, sometimes folks look at government and think, when there's a little bit less money or a lot less money, you just become more efficient. But we can't get more efficient and have that solve the problem. It's now less for less dollars, less services. And that means higher risk for everyone. Like with public health, the risks are for everyone. If we can't really do a good job on communicable disease prevention, then everyone is at higher risk. If we can't do a good job on managing exposures to environmental hazards, I think, both the Palisades community and the Inc. community really benefited from having a robust health department. But if we don't have that, then we can't respond in those ways during the crisis. We were out within hours of reopening communities with PPE for everyone. That doesn't happen if you don't have resources. This isn't about being more efficient and doing more with less. This is about doing a lot less when we get a lot less. This is a huge, huge, huge decrease in our funding. And it can't get made up if we go to philanthropy and ask for some more dollars here and some more dollars there. We need another revenue stream to get us through the next few years. And this is what the opportunity is before us now, to think about this as we definitely need to find a way to protect these services, because the impact is for everyone. Some people, those most vulnerable in our communities, those most vulnerable of our workers, will be hit the hardest and will experience massive devastation. But I think we should all understand that will be across the board in terms of the impact of losing this much funding.
And, for the health centers, this is bringing us back to the 30 years ago when we were founded in the absolute healthcare crisis, where the wait times were too long and folks jammed the emergency room. So our patients, if they can't get into us in time and their pain increases, they'll be going to Dr. Galley's EDs or other EDs and just trying to get in as best as they can. They're unfortunately, we will see services contract, things that are seen as optional, like I mentioned, food assistance and transportation, enrollment assistance, help finding housing. These things get taken away, and as well as the jobs that were created. So you've got increased unemployment from folks in healthcare jobs who then are uninsured and are also looking for places to access care. So there, as was mentioned earlier, there is no innovating one's way out of this crisis with dollar numbers that we're looking at here. This is bone on bone at this point. I should also mention that, as was mentioned with the fires, health centers, they're primary care providers, they do medical. We're not first responders, but we're second responders. We're the folks that are there in the community, taking care. We have one of our health centers burned down in Altadena. And our health centers, we have a number of health centers staffing the emergency operations center in Pasadena, and making sure that folks had access and got access to care. Similarly, on the west side in Venice, they were supporting the relief effort there. So it really pulls the rug out from under our safety net system, and there's nothing else left to catch it.
Thank you. I'm trying to track the questions. There are 2 typed questions online, and I think someone also had their hand up as well too, maybe 3 questions. I'm going to go to the first written question, and if you have questions, please just put it in the chat. That would be super helpful. So got a question here from Brenda Olmos. She's the Vice Mayor of Paramount and President of Contract Cities. She received a spreadsheet with the numbers of Medi-Cal enrollees per each city. And in Paramount, they have 57,000 residents, and 37% are enrolled in Medi-Cal. Of that percentage, how many of our residents would face difficulties with healthcare coverage?
I'll jump in, and I think Dr. Galley can offer more. For the folks that are enrolled in Medi-Cal, all of them, because unfortunately, for even for folks that aren't bound by the work requirements or any of that, if they do have to enroll, they're going to have to go through the same overwhelmed county system that is trying to keep people enrolled. So everyone who's on Medi-Cal is going to be struggling following this. And all 57,000 residents of Paramount are going to be having challenges in accessing healthcare services, unfortunately.
Dr. Galley, anything to add to that question?
I think Luisa's answer summed it up. I think certainly some people will figure out how to get through the process and check the box on what is a long list of to-dos with work requirements, but everyone is at risk of additional processes and challenges and barriers with getting their Medicaid enrollment completed and approved. And that applies to every single one of the individuals currently on Medicaid.
Let's see. I see a question in the chat from Nick Kimball. I believe this is being put forward as a general tax. What are the assurances for the taxpayers that the funds will actually be used for public health and not used for other county overhead? Also, it was mentioned that there are already cuts, layoffs in progress. It's probably worth providing that information to the public to show that DPH is already making efforts to be more efficient. Dr. Furr, I think you're probably better able to answer the second part of the question. And I think in terms of the first part of the question, Nick, on the assurances, the supervisor has put forth a spending plan, and it is certainly her priority, and certainly I'm sure it's Solis, and that when the board adopts the spending plan, this is what we stay true to throughout it. And I think, frankly, we welcome any pressure from the public and the mayors to keep us accountable. We have a Citizens Oversight Committee to keep us accountable. And the auditor will also be tracking the expenditures and making those public as well, too. But Dr. Furr, would you like to answer the second part of the question?
Sure, and thanks for that question. And it's been a difficult, almost heartbreaking, few months here as we've had to both curtail services and staff. We have been very public about this, including really presenting testimony before the Board of Supervisors at their meetings. And just last week we had to announce the closing of our 7 public health centers, clinics, and did so, and are working to make sure that those patients that we see there are transitioning their care to another community site. I think, we work extraordinarily hard all of the time on the efficiencies issues, and, are happy to, talk more about what we're doing. I think we, like all other apartments, have what we call a hiring freeze. Again, we only fill positions that are absolutely critical or in areas where they generate revenue. All other positions have been frozen now for months. We've actually eliminated, I would say, close to 150 vacant positions here as a way to really see some cost savings and be able to take that money and use it towards services that we're receiving reductions from grants or from our county allocation. We've also, we have a one device policy now that's going into effect. So, we've had people who've had, both a laptop and a desktop, or a laptop and a field instrument that they're using, and we're all going to one. We're reducing the number of people who are carrying county cell phones by over 50%, and working hard to consolidate on real estate. and make sure that, we're maximizing our use of office space and space where we see clients and residents. So, we have a long list here around the efficiencies, but if you're losing $200 million, it's impossible to conceive of any set of efficiencies that are going to raise that level of funding.
Thank you, Dr. Ferrer. I can't see on the screen, but I'm told Tim Hepburn has a hand raised. Tim, I don't know if it's possible to unmute yourself and ask your question or type it in. Oh, here you are. Great. Tim Hepburn, Mayor of the City of Laverne, very concerned about the tax increase, and our residents will go to other cities to shop outside LA County. Even though it will leave us a 0.25 left increase on our sales tax. We're concerned about how quickly this came about and how this was vetted with the Board of Supervisors. We also are also concerns how this will be sent.
Actually spent.
Oh, spent. Thank you.
Sorry.
Thank
My
you.
typing quick,
Well,
guys. I'm trying to make it easy for you, but
Thank you, Your Honor.
yeah.
Appreciate it. So, I mean, I guess a few things in response to it, and I think hopefully what you heard, Your Honor, is the hard choices facing the county, and this is why they felt, and my boss and Supervisor Solis felt it was important that be put to the voters to make those choices given what we're looking at in terms of the higher costs of medical debt, not receiving medical care, loss of coverage of workers and families across the county. You did mention the 2.25 left on the sales tax. It is true that we're taking an approach that would exempt this sales tax from any caps, so it doesn't touch the city's existing powers to tax. It doesn't affect their caps in any way for any municipal needs. In terms of how quickly this came about, the supervisor did follow the transparency process which she adopted and urged, where things go through what's called the cluster process, where it's shared with the health deputies across all the counties. And just given how quickly this cut is coming, and frankly, we're already losing over like 135,000 individuals have already dropped off of Medi-Cal in just a few months. It was imperative that we push it as quickly as we can to the voters to consider. So I hope that's somewhat helpful.
If I could just speak for 1 second, is that okay?
I think I want to be sure that we leave room for other people's with questions as well too. So why don't you go ahead and give a brief comment, and then
I'll make it very short.
you got it.
Understanding the need for this, and I do understand the need. We do have services that are great for our communities that you guys provide. Again, with so much with going on budgets and deficits and spending that was not closely watched, it's very concerning to our communities and to our residents that a lot of increases in sales tax, a lot of, not sales tax, but sanitation districts, water, sewer, a lot of increases that are going on right now. That's very difficult for our residents to do that and to meet those costs and needs. But our biggest concern is really how it's going to be spent and how it's going to affect us, concerning that there are other areas that have had some, like the homeless situation, where the money was spent in ways that weren't watched closely. But I think that's our biggest concerns. But thank you.
Thank you, Your Honor. Appreciate your comments. Let's see. There is a question from Libby Bretthauer on where can we find information in writing about the exemption from the cap. Happy to share the Ledge Council language on the exemption. I'm trying to see if I have the ability to share it here in this chat, Libby, but we can, if you drop in your email, I can be sure to send it over to you. The language is public, so happy to do that. So let me see if I can, somebody more skilled than me can add it to this chat.
Yolanda, I'm going to attempt to add it.
Thank you, appreciate it. Let's see, we have, and I apologize if I don't pronounce this. Oh, okay. Zain Obaji, I hope I'm saying that correctly, is the discussion on Supervisor Mitchell's motion to introduce this ballot measure on the agenda already for tomorrow. Do we have an agenda item number? Yes, it is on the agenda as item number 15, the Supervisor Mitchell and Supervisor Hilda Solis motion. So it's item 15 on tomorrow's agenda. Let's see. Very good. Mayor Perez, the city of Norwalk, couple of concerns with this being general tax, but not comfortable with assurances. Would be easier to accept as a special tax. Can this be changed? Also will make taxes in LA County the highest in the region, which will for sure see shopping being pushed to other surrounding counties where taxes are much lower. Could suggest instead of exemption for CAP, have legislators write measures for statewide. Could the Board of Supervisors get behind this rather than LA County? I know this is a question that our speakers can address, Your Honor, but I think we have been closely monitoring the statewide appetite for a fix, dealing with the urgency that this is coming to the county with. And there is no other currently viable, timely approach other than this temporary sales tax measure, which, if there miraculously is some revenue relief, there is in the ordinance, it does allow the supervisors to lift, never increase, but only lower this temporary sales tax measure. In terms of a special tax, can this be changed? I mean, the reality on a special tax is that is an option for getting a absolute binding to get taxes measured and paid for a particular purpose. And we saw that with Measure H, which barely passed with maybe like a 1% or so. But I think at this juncture, the proposal, after talking to different people, after seeing where people were, was doing the general sales tax with the spending plan, where the county board would commit to spending it appropriately. And again, we urge you, to the extent that you're concerned about the board staying true to that plan, please support us in that effort to do that as this moves forward. And our boss, and I know Supervisor Solis, is committed to making this spending plan and the expenditures as transparent as possible. I apologize if I only have 2 minutes left. Let's see, are there any other questions? And thank you for sharing the Ledge Council language. Are there any questions to the speakers? I don't see any others. Okay, well, seeing no other questions, I want to thank you all for joining this conversation and this candid conversation about what the County of Los Angeles is looking at, and the urgency. I hope you better understand the urgency with which we had to move and to operate. I know we don't take raising taxes lightly. It is a painful option and choice, but we saw no other options but to ask our voters to decide whether they were willing to pay this 0.5% sales tax in order to preserve critical services that they and their families need in order to work, and frankly, to keep affordable healthcare costs available to them, because otherwise there's no other option, and they would need to go to emergency rooms, which would impact us all. But I appreciate you. Thank you, everybody, and thank you for the speakers for taking your time, and best wishes.